Okay. So moving on to the tetanus vaccine course. So the first thing is to assess the wound. Is it a clean wound or a dirty wound? So most of the time, the clean wounds are usually like surgical cuts, like mild abrasion. While the contaminated wounds are stuff like gunshot injury, stab injury, something that contains inoculation of foreign body, dirt, microbes, cat bite. All those ones they are dirty wounds. So let's go with the clean wound. So somebody has a clean cut, right? And you want to give tetanus prophylaxis. So you need to be sure. So what's the status of this individual as regards the vaccination status, right? So you want to ask, have this person taken the three lifetime tetanus toxoid course? Yeah. So if that person has taken three-time tetanus toxoid course and the last time the person took the tetanus toxoid booster is less than 10 years, you don't do anything. Don't give any prophylaxis. So the person has taken the three-time tetanus toxoid and the person has also taken the tetanus toxoid booster within 10 years. So that means the person is well immune. So you don't need to give any prophylaxis. But if the person has a problem with either of them, so either the person has not completed the three times toxoid vaccination schedule, or the last time the person received his booster was more than 10 years, give your tetanus vaccine, which can come in form of the TD, which is the tetanus plus diphtheria, or the Tdap, which is the tetanus, diphtheria, and pertussis. Right? Any of them is fine. But if otherwise, that is the person has taken the three times tetanus toxoid vaccine, and the person had already been taking the booster, and the last time the person took the booster was less than 10 years, the person is okay, no prophylaxis. Okay, but for other wounds, for sorry, excuse me, for other wounds, yeah. So for other wounds, which is the contaminated wound, so you also want to go through this algorithm, but this time around you have a lower threshold for the tetanus booster. Yeah, because when the wound is contaminated, there's a very high chance of the person having the infection. So you need to be sure that this person is, well covered, against that tetanus. So you are a little bit aggressive rather than the clean one. So number one, the threshold for the booster is reduced to 5 years. So the first thing you want to access is that, okay, um, has this person taken the three courses of tetanus toxoid? If no, in this situation, you are going to give both your vaccine and the immunoglobulin, both the vaccine and the immunoglobulin, both of them. If the person has not completed the lifetime tetanus toxoid course at least three times, those three tetanus toxoid course, if he has not taken three, give your vaccine and the immunoglobulin. Okay. So if the last time the person took the booster was 5 years more than 5 years. If the last booster dose was more than 5 years, give the vaccine. Give the vaccine. Only. You don't need to give the immunoglobulin. Only vaccine. But if the person has completed the three tetanus toxoid course and the person last time the person had the toxoid was 5 years less, so you don't need to give anything. The person is okay. So that's what you just need to know. So you just have to have it at the back of our mind that if we are dealing with a clean wound, we are looking at 10 years for the booster and the three courses of tetanus toxoid. If you are dealing with a contaminated wound, you are still looking at the three tetanus toxoid course, but you are bringing down the booster, level to less than 5 years. That is your cutoff, 5 years, 5 years. And if the person has not taken three toxoid, four, the dirty, for the contaminated rather, you must always give both of them, both active and passive, your immunoglobulin and your tetanus toxoid. Your immunoglobulin and tetanus toxoid. If the problem is the fact that the person last took the booster 5 years, more than 5 years, then you know that in that situation you're only giving your vaccine, you are not giving the immunoglobulin. But if the person has taken the three toxoid and the person, took the booster within 5 years, the person is okay. You don't do anything. So that is that about the tetanus prophylaxis. Um, so looking at the bite and the stings, we have the bee and the wasp. So bee and the wasps are always being talked about with respect to anaphylaxis. So anaphylaxis, type 1 hypersensitivity, talk about the bee stings, and the pathophysiology involves release of histamine, right, from the mast cells, degranulation and the like. So you can have the histamine causing vasodilation, the edema, the swelling and the like. So because of that, you can use antihistamine or steroid to suppress the inflammatory response. If that doesn't work, or the person eventually develops serious form of anaphylaxis, angioedema, and the likes, just give your high-M epinephrine. You know, very, very important. So for most of the anaphylactic shock, the the hypotension, the wheezing, the edema, angioedema, give your IM epinephrine. But if it's something that is just mild, just maybe some skin reaction, erythema around that area, mild swelling, you can use your antihistamine and your steroids. But if the person progresses to the anaphylactic shock, give um, IM epinephrine. So moving on to the spiders. Two major spiders to take note of. Two major spiders, the black widow and the brown recluse. So the way I remember the brown recluse is the word recluse. It sounds like crosses, clues, crosses. So the brown recluse spider secretes a necrolytic or a necrotizing toxin. So that is a toxin that has the ability to induce skin necrosis. Why the black widow will just make you shiver, you know, it just make you shiver. So they cause muscular spasm. So they can cause abdominal pain that will even mimic acute abdomen. You think the person has maybe ruptured acute appendicitis or strangulated inguinal hernia or something. The abdomen will be so rigid and painful. So, that's the black widow. So think about the black widow as something that makes you shiver, that you undergo spasm, hypercontraction. Why the brown recluse is something that causes necrosis, recluse, necrosis. And when we are thinking about necrosis, DIC is not too far away. So DIC can, cause necrosis too, or necrosis can progress to cause DIC, right? So that's that about the spider. So what do you do? Somebody comes with a spider bite, and it was said that the person is having rigidity, spasm of the muscles, maybe of the abdomen or the arms or whatever part is affected. Think about the black widow that causes shivering, hyperrigidity, and you have to give your antivenin. That's the antibody against the venom, right? Yeah, so the antivenin. So it's been said that calcium gluconate doesn't work again. So don't pick calcium gluconate in the option. Just go for your antivenin JJ and you move. So for the brown recluse, that's the one that you have to think about. Necrosis is very similar to the word recluse, right? Necrosis, you just notice skin discoloration becomes dark, necrotic in nature. You're having blood oozing from all the sides, DIC is already setting in, right? They can even show us the laboratory values. You see that the everywhere is deranged, your D dimer is elevated, fibrinogen is low, fibrin is high, all the APP, TT, the PT, they are prolonged, okay, this is likely to be DIC situation. So what you do is just you give cold compress to reduce the progression of the necrosis, or you use Dapsone. So Dapsone and cold compress have been proven effective to reduce the progression of the necrosis following the brown recluse spider bite. Or you do your skin debridement. You just remove the necrotic tissue. Of course, you don't want DIC to set in, because the quicker you debride, the lesser the chance of progression to DIC, and the better the chance of healing, because you have to remove the necrotic tissue. So don't forget, you don't use Dapsone in people that have GCSBD deficiency. So that's that about the black widow. The scorpions. So the scorpion venom typically causes, like, it's very similar to um, the black widow spider. in that it also causes like sustained depolarization of the nerves and the muscle. So that's the way I want us to remember it, because what this toxin does is that it prevents inactivation of the sodium channel. So you have a sustained depolarizing impulse. So think about the neuromuscular tissue, think about the autonomic nervous system. Yeah, think about the autonomic nervous system, think about the neuromuscular system. So I used to use rabies, but I know that many people can get confused. So because if you look at the way someone that has rabies present, it's very similar to this scorpion bite. You see them having hypersalivation. They are excessively producing saliva. You see them having muscular weakness. They have muscular paralysis. They have sustained contraction too of the muscle. So it's kind of looking like rabies kind of presentation. But if you don't remember that, just stick with your neuromuscular and autonomic problems. It causes sustained hypercontraction of the muscle. So that's why it can cause, cranial nerve dysfunction. So sustained contraction of the the throat muscle with weakness can cause dysphagia, right? Because of paralysis of cranial nerve 9, cranial nerve 10. So they cannot swallow, they have dysphagia. So sustained contraction of the muscles of the extremities too can cause fasciculation, jerky movement, right? Which can look like seizure. So they have sustained contraction of the muscles of the extremities, which is actually in form of fasciculation and jerky movement, you know, due to the sustained sodium depolarization. And also it causes abnormalities within the autonomic nervous system. So they have tachycardia, they have diaphoresis, they have hypersalivation. So the way I remember the last part is that hypersalivation can, lead to aspiration, which can impair respiratory activity, leading to respiratory compromise. So the scorpion bite, think about problems affecting the nerves, the muscle, and the autonomic nervous system. So the nerve and the muscle, because we know that this thing is that sodium channels are not going off. They are readily sustained in their contraction. So that means that the muscles will show features of fasciculation and jerks, which look like seizure, right? And it can also affect the cranial nerves too. So hypercontractility of the throat, dysphagia, right? The affectation of the oculomotor nerve, you see sustained eye, movement, the eye, like jerky eye movement in all directions, kind of. So abnormal eye movement due to affectation of the oculomotor nerves or the nerves controlling the extraocular muscles, and due to affectation of the cranial nerve 9 and 10, they can have dysphagia, you know. Then contraction of the muscle of the extremities too. They can have um, jacks and the fasciculations. And the autonomic nervous system, they are hypersalivating, they are having tachycardia, they are having diaphoresis. They can easily aspirate because of their dysphagia, and they can have respiratory distress. And even from the hypersalivation, respiratory distress. So what do you do? If they have any neuromuscular, that is maybe the peripheral nerves, problems causing hypercontraction of the extremity muscles, or they have problem with the cranial nerve causing abnormal eye movement or dysphagia. So in that situation, you have to give your antivenin, right? Give your antivenin. So, but if there's no antivenin available, you can give your benzo, your sedative, and your analgesia to control the pain and the spasms. Don't forget, we have said it. Sustain muscle contraction from inactivation of the sodium channels. That's what is causing the problem. So they can having sustained contraction, pain and spasms. Benzo will take care of that. So that's why part of the complication, because of sustained contraction, they can have rhabdomyolysis, they can have hyperkalemia. Because of the dysphagia, excessive hypersalivation, they can have aspiration, which can cause pneumonia. So the snakes, the the common snakes in the US, the ratu, the copperhead snakes, they belong to the crotaline family. So these snakes too, cause something that is very similar to the brown recluse spider. We have said the black widow is like the scorpion. Why the crotaline snakes are like the brown recluse? Because skin necrosis, they can cause DIC. Yeah. So once the toxin gets in, because it's vasodilation, which can lead to distributive shock, hypotension everywhere, tachycardia, and Necrosis of the overlying skin with eventual DIC, if not quickly attended to. So what do? You know, just like other ones, you give their antivenom, right? Which is a crotaline polyvalent immunoglobulin, immune FAB. I'm sorry about that. The crotaline polyvalent immune FAB. So you're just using the FAB fragment of the antibody against that venom. That's essentially what they are talking about here by the big names. So the immune FAB fragment of the antibody against that toxin. That's the mainstay of the treatment. Then you keep that affected part below the heart. So if it is leg, you keep it below the heart. You don't raise the leg up, because you want to slow down the time it takes for it to travel to the heart. Because once you get to the heart and stop the heart, bam, person is dead. So never pick other things in the option like use of compression band like people normally do. They try to apply compression band above that site and they try to suck out the toxin. No, that would be wrong. So no use of compression band, no use of tourniquet. You don't do prophylactic fasciotomy. It doesn't help. You don't have to cut out that part. Resection, no. So they are outdated treatment or they are ineffective. You don't choose them. Just like you don't choose calcium gluconate again when it comes to the spider bite, right? So do not choose tourniquet application, compression band. Just put that part below the heart and give your antivenom. So that's why in the hospital they might ask for the species of the snake. So if it's the crotalin, they give the appropriate antivenom. So for the dog and bite, we have talked about this because they have a very high chance of causing infection, right? Pasteurella, the cranial Salivagos canimorus, the Pasteurella multisoda, the staph, the strep, very common infections, and they can also be a source of rabies and tetanus. And we have gone through the algorithm. So depending on the site. So usually the first thing is once you see that the bite is from a cat, you must always give your antibiotic, which is your amoxiclav, clavulanate. Very, very important. So if it's a deep bite, involving the hand and the feet, just like I've mentioned earlier, or the person is someone that is immunocompromised, HIV/AIDS, cancer, you have to give the antibiotic because there's a very high chance of developing infection. So somebody having a puncture wound that is deep, somebody having bite to the hands and the feet, even if it's tiny, because that area is less vascularized, so there's a very high chance of developing infection. Or the person is immunosuppressed, you must give your antibiotics. And people with puncture wound, people with bite to the hands and the feet, in addition to giving the antibiotic, you must not do your primary intention closure. So you must allow the wound to heal by secondary intention. Allow granulation tissue to grow after you have cleaned and debrided, because you have a very high chance of inoculating very large amount of infection in these areas, the puncture wound. So you must clean as much as possible before and you don't close. So if you go and close, there's a potential that you have closed infection with it. So allow it to heal by secondary granulation. When it's puncture wound, when it's injury to the hands and the feet, please, secondary intention is a mechanism of the healing. So, and if you also have the puncture or the bite, you must give your antibiotics, amoxiclav, right? Don't forget the antibiotic. And if it's a situation of a cat, because you have a very high chance of having retention of the teeth, some of those teeth within the wound, so you must do imaging to rule out implantation of those fragments in the wound. For humans, similar thing, infection, give your amoxiclav clavulanate, because the person might have inoculation of staph, strep, or even echinella. So you must give your antibiotic cover after you have done a normal cleaning. You'll have done the normal cleaning and then wash that area and give you antibiotics. So for the rodents, they have a low risk of transmitting the all this infection, the rabies, tetanus. It's not very common. So, but they carry they have a high tendency of carrying leptospirosis, right? So you just do your local wound care, just clean it, run it over running water, clean that area, and apply your dressing. That's all you do if it's rodent. But you watch out for leptospirosis. Leptospirosis is something that can develop with them. Yeah, because the leptospira spirochete is carried by the rodents. Then the last is the shellfish. The shellfish is vibro Vibrophonicus. So we have talked about this in our microbiology section before. You can find the Vibrophonicus in shellfish. So this organism usually thrives in area with high amount of iron load. So people with hemochromatosis have a very high tendency of developing this infection. So somebody has a pre-existing liver disease, particularly hemochromatosis, and the person has maybe a wound that is contaminated with seawater, right? Because shellfish, you can find them in sea. You can have introduction of this vibrovenicus into that injury, and what happens? You start seeing features of necrotizing fasciitis. It starts burrowing down the wound, down to the fascia, to the muscle, causing necrotizing fasciitis. So you start seeing discoloration of that area is going to be brownish. The area is going to be very painful. If you percuss or touch that area, you hear that crepitation, right? It's going to be foul smelling too. It can be smelly, you know. And of course, you are going to see the bullous lesion there, hemorrhagic bullous lesion, necrosis of that tissue, crepitus, you know, all those kind of things should raise your suspicion from necrotizing fasciitis, particularly when there's exposure to seawater, in people with a background liver problems like hemochromatosis. So what you just give is your IV doxycycline and your ceftriaxone as if you are treating PID with Neisseria and chlamydia. So you give your IV doxy, IV ceftriaxone, and you debride always. You debride, you debride, you debride, you debride.